session, though the name indicates SICS, it is a way back 30 years old topic. I'll make it into a modern topic. I have the experience of 4 decades in this, where some of my students are here. So this is my experience. So there are my books which are available in online. You please go through them. This is a case of femtocataract. I am also a femtocataract surgeon. So where the nucleus is made into soft, the entire thing is aspirated and we inject the lens at the end. Why I am showing this video is, as a small incision surgeon, keep this in mind, do the surgery. I should compete with this fellow. So a femto is a rich man diet which can be distributed the same cost to so many poor patients. The learning curve for small incision is much smaller or shorter than the phacosurgeon. For these cases, you have to depend on SICS. These are the cases you should be thorough with the SICS. Morning we have seen with the soft cataract, they are struggling to do the phaco. I can do SICS in these cases in 2 to 3 minutes. For black cataract, they damage the cornea. I will not damage it with SICS. There is a corneal opacity, you can remove the nucleus in toto. You need not make into small pieces in phaco. The small incision fellows are hypermature cataracts, whereas the femto fellows are early 6/6 cataract. When there is a failure in the mission, you cannot postpone the case, you can proceed with SICS. To compete with phaco fellows, you have to acquire some of these modern gadgets like topographers, modern biometers, high-end viscose, bimanual manuals, and vitrectomy and things. When you are investing, don't invest on these two. You are investing on the car which is used for few hours, investing on jewelry which is kept in the locker. This investment you keep on this high-end equipment. The advantage of SICS is the wound is much stronger than the phaco wound, and you can dispose all your used equipment at the end of the case or at the end of the day, so that there is no toss, no infection. So for capsulotomy, you can use 1 rupee needle or 4 crores machine. The IOLs used is, you need not stick on to PMMA. You can shift to foldables, you can shift to premium lenses with the SICS. The notion is, when SICS, this should be PMMA, need not be. What is the advantage of foldable is no PCO. If you implant hydrophobic lenses, no PCO. You can compete, I can also implant premium lenses. For phaco fellow, you require 6 organs like 2 hands, 2 legs, 2 ears to hear the sound. Whereas the SICS fellow, they can close the ears, hear the music and do the job. The steps for modern SICS are, you require a preoperative front side of the cornea topographer, back side of the cornea endothelium, the back side of the eye OCT, and a good biometer. So with this, you can promise the patient with 6/6 or 6/5 vision. Anesthesia, previously we used to bombard the eye. Don't use those long needles. Use a short needle. It is a true perfect peribulbar. Otherwise, subtenon's injection don't perforate the globes. Previously, we used to put a superior rectus stitch for the SICS. If you put superior rectus stitch, it will result in ptosis. Avoid the superior rectus stitch. The conjunctival peritomy, we used to aim for 180 degrees. Don't do that. the conjunctiva is necessary for your brother is a glaucoma surgeon. The next thing is cautery. If you do cautery, it is a crime. Cautery results in sin. Sin means sterile necrosis of the sclera. So surgically induced sterile necrosis of the sclera, this is one of our case referred to me with a necrosis of the sclera and prolapse of the iris as well as ciliary body. How to avoid this cautery is, you can put 1 or 2 drops of adrenaline or use eraser cautery. So a tunnel that needs no toric IOLs, even though the cylinder, you can correct the cylinder by adopting this technique. There are nomograms to correct your cylinders. So in the anterior capsular rhexis, you want central circular correct rhexis, which is used with a rhexis marker. 5 mm rhexis markers are available, which you can do correct rhexis. So this is my old video in 90s. So I prepared where there is a rhexis, afterwards hydro procedures. So hydro dissection, hydro delineation and prolapse of the nucleus and expression or the delivery of the nucleus with visco. So here we used to select, those days the cases as NS1, NS2 soft cataracts, and I used to do the SICS, hard cataracts. I used to do ECC those days. Nowadays, no exception. Any cataract you can do SICS. So that is my 90s video, how I used to do the rhexis, polishing of the capsule, and even you can dial these lenses with the help of your Simco. So in the modern SICS, you see the incision is called as smart incision. What is the smart incision is? Incision along the steeper axis. So the steeper axis in majority of the time it is temporal. So temporal incision, so you see how the fixation is fixation with a ring, and the rhexis marker, along with the marker you make a perfect rhexis. You can enlarge it depending on that. Generally we enlarge to 6 to 6.5 thing. Depending on your astigmatism, you can plan the thing. You prefer always with the visco expression. The another important thing I teach is do with bimanual IA. Don't use Simco. Bimanual IA gives smaller openings, well-controlled AC, and it will open the capsular bag. You can thoroughly, 100% you remove the cortex, and even you can polish with bimanual. See how I am closing the conjunctiva. Conjunctiva is closing by fibrin glue. Fibrin glue. The best dressing for the eye is the conjunctiva. So this is a case of subluxated cataract where I can do the SF lens, whereas the phaco surgeon generally refers to retina surgeon. So this also, the entire lens is expressed as intracapsular lens by injecting Helon, not the methyl cellulose. Inject the Helon, prolapse it and suture. What extra instrument you require is 10-0 proline. So this is for the beginners or the postgraduates, how to do the video is not coming. Hydro dissection, the clue is they lift the anterior capsule. Generally they inject there only at the margin, no dissection. You pass nearer to the equator and inject it. Half, quarter cc is enough. So hydro dissection, you depress this 27 gauge cannula until it touches the skull and separate the skull from the scalp. So the other technique, you feel, the student feel this rhexis is small, the nucleus is large. It is, the button is large, buttonhole is small. You pass this and make the rhexis vertical instead of circular. In the vertical rhexis, it goes. That means don't do vertical rexes. At that time it stretches as vertical and prolapse it. So this is how again I express the nucleus with visco. The clue or the trick or the tip here is depress the posterior lip, continuously inject the visco, use the large visco cannula. The technique here is the train going in the tunnel. So the train going in the tunnel means you depress the posterior lip, elevate the anterior lip, traction horizontally. The student always tries to lift it. If you lift it, you are removing the endothelium. Don't lift. Press to the rails. It will come out. Your cornea is clear. The other thing is divide the nucleus in the AC. The trick here is you take a cannula, cut it, to and fro motions, inject the visco, you get the separation, and you can deliver these nuclei in 4 mm incisions. The other method I invented is the nucleus is cracked in the tunnel. So that the clue here is you prepare your own vectis having a triangular shape, not as a circular. Triangle, the tip of the triangle is anterior, that sharp edge will cut the nucleus into 1/3, then push it back in the longitudinal fashion, you can deliver it so that you can minimize the size of the incision. This is how what I teach the recently the pars plana vitrectomy for an anterior segment surgeon. What you need is a trocar and cannula which your friend, retina friend is using. They are disposable. So you take a trocar and cannula, how you have to push this trocar and cannula, you learn 4 millimeters from the limbus and remove it. So now this is a subluxated hypermature cataract. Again I am delivering with visco. So then start doing a vitrectomy which is minimal and avoiding the hydration. At the end you remove the cannula and there is no need of suture, and the patient also doesn't know where you have done the surgery. So that is called pars plana vitrectomy. So this is a fish hook method where you can deliver hardest nuclei. This all you know. If it is a very soft nucleus, as you see in PPC, you can divide like this with the help of choppers. So this is blue menthol technique. For the paucity of time, I am going fast. So this, even today we are doing this technique in our institute Medivision. So where you have to maintain the anterior chamber maintainer and depress it. What is the fun of this is you are maintaining the anterior chamber throughout the procedure. Next day cornea is clear. Snare technique, the Zeiss people are supplying the snares, but they are charging 12,000 rupees. So the next thing is sandwich technique. Each and everything everybody knows it, but the trick here is the dialer will help to protect the endothelium and the cornea. So today what is different from that day is thorough pre-operative evaluation with costly equipment, specular microscopy, topographers, and OCT. All are costly. Don't think they are not. They are the instruments for FACO fellows. They are the instruments for you also. Then topical anesthesia, you can do it. So don't use superior rectus suture. Make the conjunctiva as small as possible, 5 mm. You don't cauterize too much. It is a crime to cauterize. Then use a smart incision, not the small incision. Smart incision means depending on the astigmatism. Use sharp instruments, and the rexis you measure and do it. The nuclear delivery, visco, either blue menthol or visco delivery. Cortical cleanup, always use bimanual, not your Simco. So the hydrophobic lenses. Don't think hydrophobic lenses are those fellows, or FACO fellows. It is for you because it avoids the PCO. If there is a PCO, what the patient says is, doctor, your surgery is failure. Again I got cataract. Again my vision is fallen. So don't close the conjunctiva with cautery. You feel happy with cautery, I closed it. Cautery means you are damaging the conjunctiva. So do use with fibrin glue. So at the end, remove the visco. Think that the visco is a foreign body. So because visco causes inflammation and raised pressure, you think it as a foreign body, remove the foreign body, and best dressing is the conjunctiva, best shield is the lid. So the post-operatively, don't use the list of medicines, use only 2 drops, minimal medication, maximum outcome. The same can be served in a small incision, same served in a femto. It is your choice. Thank you for listening.
Thank you, sir, for your excellent presentation. And the practical tips covered in SICS were really, really helpful to all of us, sir. I think now SICS definitely does play a role apart from phaco whenever we are trying to deal with especially hard cataracts, and if you are a beginner in phaco, and even sometimes if there are other complications like, where there is compromised endothelium, even then also we can definitely go for SICS in difficult cases. So thank you, sir. Any questions from the audience?
Yeah. I'm happy to answer. Eraser cautery is, it is similar to your ball point. Surrounding is one electrode, central is one electrode, isn't it? Your ball point, central is the needle, surrounding is the 2 electrodes are there. It delivers minimal energy. Erase it. So it will erase the smaller capillaries. So that's why they are called as eraser. It will not hurt your sclera. So we are hurting the vessels, not the sclera, isn't it? So the cautery you have seen, one is the fire, another is the petrol. Fire is the cautery, petrol is the steroid. So next day onwards you put steroids. Some of the patients even give oral steroids, isn't it? All the steroids and the damage to the sclera, scleral shrinkage, scleral necrosis, and it attracts a lot of astigmatism. So that's why you wait, it will stop. So how long you have to wait? Till the bleeding time, till the clotting time. Every tissue, the blood will stop, even you cut the inferior vena cava. Yes? Yeah, fibrin glue, what, you want brand or how? You want, the Reliance people are supplying, the best is Baxter. I have no financial interest. You use a Baxter, suppose you have posted 50 cases. For one vial, you can use 50 cases, 50 drops. 1 drop is enough. Don't put second drop. Second drop is against the enemy. It costs a thicker. 1 drop of this, 1 drop of that. Shush. So next day, you can say, I have done phaco. You can remove your patch after 3 hours. Yes? Same you apply for your pterygium. Pterygium glue only. See, nothing like if you deposit the tissue in the same place without hurting. The patient will appreciate you. You have done a very good job. Yes? I am better than phaco, I am telling. Phaco fellows cannot correct the astigmatism. I can correct astigmatism. Same time I am a phaco fellow. Same time I am a femto fellow. But I can correct my astigmatism, but not with phaco. Phaco, I always advise toric lenses. Why means there are nomograms, go to it, for which the best fellow is Jagannath Bormani. He has given very nice nomograms. If you want to correct 1.5, if you want to correct 1, if you want to correct 2. Liberally you can give incision. Straight incision will cause more astigmatism. Frown incision will cause less astigmatism. Temporal causes less astigmatism. Superior causes more astigmatism. If you are closer to the cornea, more astigmatism. By that you can correct it. How you will become master, I don't know your name. Agam, what you have to do is, you calculate your own cases of 20 or 30. Oh, with this I can correct like this. So I studied 200 cases those days of my SICS. Ultimately, my astigmatism was 0.62. I can correct with my incision 0.62. The other, my own assistant used to correct 1.5. His correction. Yes. Fibrin glue? Fibrin glue, instantaneously it will attach. While same day, same day you cannot keep for the next day. Same day you have to complete. If you are a volume surgeon only, you can afford, because it is 10,000 rupees. Relicil also, same day. But 4,000 means that is half of the dose. But it is less effective than that of Baxter. You try both. But at least you have 10 cases, it is valuable. 10, 20 cases. Or share with your friend. No, it is not related to depth, it is the strength. Depth is related to the strength, not with the astigmatism. Astigmatism is due to the extent and the architecture. If you make a square, almost nil. Whereas if it is make a horizontal, it induces. If you are closer to the cornea, it induces. Okay. So in my experience, okay. So in my experience, depth is not matter. The depth always I go for 1/3 to half the thickness of the sclera. It is just 1 to 1.5 millimeters away from the limbus. No, no. Where do you get from tomato serum? Yeah. No, no. No need of serum. Same blood you can use, but you are not sure of it. So sometimes it will come out, isn't it? If you are sure, means you have to use fibrin. You can try. See, some of our own colleagues, they are neither cauterizing nor using fibrin. They just deposit the conjunctiva. Next day, okay, but not 100%, isn't it? We need 100%. Even one patient is unhappy, that day we won't sleep, isn't it? My volume is 100 patients, but one patient is unhappy means, we won't get the sleep. I want 100%.